Hello friends, this is a short presentation about a very common condition which is very distressing for the family and the child, that is bedwetting. In this presentation you will see a small video which explains this condition fully, and after that it will be followed by some explanation of the facts by me in few minutes duration presentation. So stay connected, keep on watching. Thank you.
You are exhausted. You're doing extra laundry every morning. Your child is waking up embarrassed. And because they are now 5 or older, you're starting to wonder if you are doing something wrong. In pediatric medicine, involuntary nighttime wetting in a child aged 5 or older crosses the threshold into a clinical diagnosis, enuresis. Before we look at treatments, we have to clear the air. Bedwetting is not a behavioral choice. It is not laziness, and it is certainly not an act of defiance against you. This chart shows the natural drop-off rate. It starts high at 15% for 5-year-olds, but plummets to 1 to 2% by age 15. For the vast majority, this is simply a maturational delay. Their nervous system and bladder control need time to sync up. Because this is a developmental delay, traditional discipline actively makes the problem worse. Scolding a child for something they cannot physically control breeds deep resistance and damages their self-esteem. Instead of waking up relaxed, the child goes to sleep with severe anxiety, tensing up and fighting their own body. Since enuresis is a medical condition, you have to permanently drop the disciplinarian act. The path to dry nights requires you to become your child's clinical partner. Before choosing a treatment, you need to triage the symptoms. We have to determine if your child fits into the primary, secondary, or complicated pathway. This flowchart maps out the diagnostic triage. We start right here at the root question. Did the child ever have a dry period that lasted at least 6 months? If the answer is yes, they have regressed. This points to secondary enuresis. The trigger is usually an external psychological stressor, like the birth of a sibling, or an underlying organic disease, like a urinary tract infection or diabetes. If they have never been consistently dry, we follow the no branch and check for daytime symptoms. Are they experiencing a weak stream, burning, or daytime wetting? If daytime symptoms are present, this indicates underlying bladder dysfunction. You need to bypass home remedies and schedule a pediatric workup, which will likely include a urine analysis or an ultrasound. There is also a common complication that closely mimics a bladder issue, functional constipation. Watch your child's behavior during the day. If you see this retentive withholding posture, standing rigid, legs tightly crossed, they are actively trying to avoid passing stool. This chronic retention creates a severe internal feedback loop. A large fecal mass accumulates and presses directly against the bladder, reducing its capacity and triggering both fecal soiling and bedwetting. This frustration is telling. A child can pass small amounts of stool frequently and still be severely constipated. Frequent movement doesn't prove the system is clear. If your child is constipated, the trade-off is time. You will have to endure months of treating the bowel impaction with dietary changes and laxatives before the bladder issues will resolve. Ultimately, any yes to these red flags means you are dealing with a complicated case. Stop trying to fix it at home and seek a pediatrician to treat the root cause. If your child cleared the triage without red flags, they fall into the most common category, isolated monosymptomatic primary enuresis. For these children, active medical interventions should wait. The required first-line therapy focuses entirely on baseline behavioral and fluid regulation. This diagram breaks down the specific hydration schedule you need to implement, known as the 40-40-20 rule. The goal is to front-load their fluid intake. They should drink 40% of their daily fluids in the morning, 40% in the afternoon, and strictly limit intake to 20% in the late evening. Alongside this schedule, you must strictly eliminate bladder stimulants from their diet. High-sugar drinks, caffeinated beverages, and fizzy sodas are completely off the table. For children between 5 and 7 years old, you pair this fluid regulation with motivation therapy using a structured reward system. This is a motivation chart, but the layout is crucial. You must reward adherence to healthy pre-bedtime habits, like going to the toilet right before sleep. Do not tie the rewards solely to a dry morning. The child cannot consciously control their bladder while asleep, so rewarding only the outcome sets them up for failure. This baseline management builds a vital foundation of healthy habits. The trade-off is that it requires extreme daily consistency from the parents. And for older children, it often isn't enough to solve the problem completely. If your child is over 7 and you've seen no improvement after 3 to 6 months of baseline management, you reach the active therapy stage. At this point, parents have to choose between two opposing interventions: enuresis alarms or prescription medication. This schematic shows how an enuresis alarm operates. A moisture sensor is placed in the child's undergarments and connected to an alarm unit. The instant the undergarment gets wet, the alarm sounds. Over repeated exposures, the sleeping brain learns to wake up. The trade-off here is severe. Alarm therapy requires 3 to 6 months of intense sleep disruption for the entire family. Parents must have the patience to wake up, help the child to the toilet, change the bedding, and reset the sensor multiple times a night. The alternative is pharmaceutical, desmopressin, which is usually given orally as a melt-in-the-mouth tablet about an hour before bedtime. Desmopressin is an antidiuretic. It temporarily forces the kidneys to reduce urine production overnight, often resulting in immediate dry nights. But taking this medication requires you to enforce an absolute boundary on nighttime drinking. Fluids must be strictly restricted to a maximum of 200 milliliters starting an hour before the dose. Failing to restrict fluids can cause a rare, dangerous drop in blood sodium. Furthermore, once you stop the medication, the bedwetting will likely relapse. You have to choose your hard, the grueling, sleep-depriving path of the alarm for a permanent cure, or the high-monitoring, fluid-restricted path of medication for immediate temporary relief. There is no zero-effort cure for enuresis. The right choice depends entirely on your child's age and your family's current capacity for stress. Look at this matrix. It plots the speed of results against the amount of parental effort required. Reward charts sit firmly in the slow speed, medium effort zone. Alarm therapy is slow, but demands the highest possible effort. Desmopressin works fast, but requires high monitoring. Baseline management is the right fit for patient parents of 5 to 6-year-olds. Alarms are for highly motivated families seeking a permanent cure. Medication is best used for temporary, immediate relief, like protecting a child's social confidence before a school trip. Stop fighting the child. Start keeping a bladder diary to track the data, and consult your pediatrician to build a roadmap to dry nights that actually works for your family.
So friends, you have seen in this presentation that enuresis can be primary or secondary type. Whenever a patient comes to us, we should ask the question whether there has been a dry spell of more than 6 months in the night or not. And if the patient has achieved that, we label it as secondary enuresis and try to find out the cause, whether it is because of psychological reasons or because of any other reason of bladder or outside bladder. If the patient is above 5 years and still the patient is urinating and there is no dry spell of more than 6 months achieved so far, in that scenario, we should wait for a year or so. But if the patient is very distressed, we can start alarm therapy or the drug therapy after telling the advantages and disadvantages to the parents, and most importantly stressing upon the fact that punishing the child or scolding the child does not bring any benefit. So I hope you have understood what nocturnal enuresis in children is, and I hope that from this presentation you have gained the insight into it. Please feel free to comment upon the presentation. Thank you for watching it till the end. Thank you.